Thanks, John. This past year, John and I had a spirited discussion over dinner in which I expressed great enthusiasm for CAR T cells, and John was more skeptical. So I think maybe he's called on me with this invitation to put my money where my mouth is with this presentation. So I think the experience that John has with his patients asking about this technology reflects all of what we see. I think there's been a lot of buzz, there's been a lot of lay media attention to CAR T cell technology, and so patients, whether they are potential candidates for clinical trials or not, are asking these questions. So it's important for us to sort of revisit the state of the art of where we are now and look a little bit into the crystal ball about where this technology may go for the future. There we go. My disclosures are there and are noted in your handout. So whenever we're thinking about a new treatment, the first place we have to think about applying it are, of course, in our current unmet medical needs. And this is what I would consider today the most pressing unmet medical needs in B-cell malignancies. Within diffuse large B-cell lymphomas and high-grade B-cell lymphomas in the latest WHO categorization, we know that we can identify very high-risk subsets with poor outcomes with standard R-CHOP-based therapy. Thinking here, double hit lymphomas, double expressing lymphomas, of course, high IPI patients, et cetera. Patients with refractory DLBCL that relapses quickly after autotransplant, that relapses quickly after R-CHOP, we know, have a very low cure rate with high-dose chemotherapy, and of course patients relapsing after autotransplant have very few tools that can induce sustained remissions. Mantle cell lymphoma, we've just heard extensively about, is still an incurable and usually fatal disease, despite all the modalities that you heard about so elegantly just before. Follicular lymphoma we don't think of typically as unmet medical need, but we do have very nice data that tell us that those patients who relapse within a couple of years of their initial standard chemoimmunotherapy are those patients who actually have a very high risk of dying of their follicular lymphoma, and we need to do better for them. And then finally, in CLL and SLL, of course, we've got a bevy of targeted therapies, but most of these are not inducing sustained remissions in all patients, and so particularly those patients who have relapsed or are refractory to BTK inhibitors, BCL2 antagonists, I would say still denotes our unmet medical need in CLL. And these are the populations of patients that I'm thinking about as potential future candidates for CAR T cell therapy. I'm going to focus today on diffuse large B-cell lymphoma and high-grade B-cell lymphomas because I've been asked to think in the near future about who are going to get these therapies, but I think that those in the outside of the red box are potential candidates for the more distant future, which I'll just touch on briefly at the end. So when we think about these unmet medical needs, I think one that we're all used to thinking about, of course, are these double hit lymphomas with translocations of MYC and BCL2 and or BCL6. This is some retrospective data from a multi-center set of institutions that shows that the median PFS is about 11 months, the median overall survival is just under 2 years, and there is a tail on this curve, but that tail on the curve is only about a 40% progression-free survival with double hit lymphomas. These so-called double expressing lymphomas without dual translocations but with immunohistochemical expression of MYC and BCL2 are a much more sizable group of patients in the upfront DLBCL category. So this constitutes, among different series, about somewhere between 20 and 29% of patients with diffuse large B-cell lymphoma, while double hit lymphoma is only in the range of 5 to 6%. So this is a fairly common population of patients, and what you can see, as highlighted on these slides, is that those patients who have who have expression of MYC and BCL2 on the lower panel of both of these two separate studies have a poor prognosis with about a 40% overall survival. Though the slope on these curves does not drop as quickly in double hit lymphomas, the overall trajectory is ultimately similarly poor, while those patients who express one but not the other of either of those markers seem to have a very good prognosis. And then if we think about those patients with refractory or relapsed disease, we can look at this multi-center analysis of patients compiled from 4 different data sets, just about 600 patients were looked at, and looked at chemorefractoriness. And chemorefractoriness here was defined as not achieving response to either first-line therapy or second-line therapy, or relapsing within 1 year of auto stem cell transplant, which I highlighted earlier, is a high-risk tool group as well. And what you can see is, regardless of the definition used by the color on those survival curves, that the survival is absolutely dismal, with about a 6-month overall survival in all of these refractory patients, and you can see the slope on that curve really drops like a stone. So for these chemo-refractory patients, we absolutely need better therapies than what we have available today with standard chemoimmunotherapy platforms. You can also see that just responding to these treatments is unlikely, with an overall response rate in only about a quarter of patients and an extremely low complete remission rate of 8%. So I think this is sort of the benchmark in chemo-refractory large cell lymphoma that we have to think about novel agents and how they might perform. And so CAR T cells might be what we could consider an ideal immunotherapy. Rituximab is great. We've been using immunotherapy for decades in lymphoma, but it's a passive immunotherapy as opposed to an active immunotherapy which can directly target lymphoma cells. This is what we look to allogeneic stem cell transplant for, but of course you need the good fortune to develop a graft versus lymphoma effect and to not develop a graft versus a host effect, not to mention the potential toxicities of long-standing immunosuppression. So the idea with a CAR T cell is that the lymphoma cell has an antigen on its surface here in that blue circle, which we'll consider CD19 for the purpose of this discussion. And our T cell has receptors that don't match the antigen on the surface of the lymphoma cell, or else it would be depleting all of our innate B cells. So if we use a vector, usually a lentiviral or a retroviral vector, we can engineer this T cell to express a receptor that in fact matches that CD19 or other antigen on the surface of the B cell, that we can then activate that T cell, and that T cell will then induce cell-mediated cytotoxicity on that tumor cell. And the potentially particularly ideal element of this is that this is a living drug, that this is a T cell that can then persist in circulation and continue to induce anti-lymphoma effect. So we know that T cell killing of whatever its target antigen isn't as simple as expressing simply a receptor against that antigen. And so shown here, you see on the far left your T cell receptor against a tumor antigen. And so we could potentially induce an anti-CD19 receptor on the surface of a T cell. But we also remember from our early immunology coursework that T cells require co-stimulation in order to be activated and exert their efficacy. And two dominant ways that this co-activation happens is through CD28 and CD80 signaling, or 4-1BB ligand signaling. And so the current techniques in making CAR T cells is that these cells are engineered not only with an anti-B cell receptor, mostly CD19 with the furthest along products, but also with a co-stimulatory domain with either CD28 and 4-1BB in order to activate that T cell and ensure optimal anti-lymphoma activity. And initial phase 1 studies, which are obviously with small number of patients, have all looked very encouraging. There are 3 large groups that looked at this initially with the most mature data. The NCI used an anti-CD19, CD28 co-stim domain, all signaling downstream through CD3 zeta. They published their data in JCO, and 4 of 7 relapsed DLBCL patients achieved a complete remission. At Penn, they produced an anti-CD19 4-1BB, also CD3 zeta signaling, and 6 of 15 patients with DLBCL achieved a complete remission. And then at the Hutch, they also had a CD19 4-1BB, and they presented data showing that 8 of 21 patients in their study achieved a complete remission. It was even higher in those that received fludarabine and cyclophosphamide conditioning prior to CAR T cell therapy. So very small numbers of patients, but refractory large cell lymphoma with a sizable proportion achieving a CR, where we only expect with standard treatments, I estimated an 8% based on the data set that I previously showed you. All 3 of these technologies have been licensed commercially, the NCI to Kite Pharmaceuticals, UPenn to Novartis, and the Hutch to Juno Therapeutics. And those are the compounds that are furthest along in clinical development and closest to potential market. The furthest along is this molecule from Kite called Kite C19. This is an anti-CD19 CAR T cell. This is their ZUMA-1 trial, which is the phase 2 study in refractory diffuse large B-cell lymphoma. This data was presented at this last ASH meeting. I mentioned that this compound is an anti-CD19 with signaling through with co-stimulation from CD28 domain and downstream signaling through CD3 zeta. This was based on phase 1 data, which showed an ongoing CR rate of 43% at 1 year, which is pretty remarkable for a high-risk DLBCL population and warranting this phase 2 study. This is the schema for this study. You can see that 111 patients were enrolled and leukapheresed. They all underwent standard conditioning prior to receiving CAR T cells with fludarabine and cyclophosphamide, and then at a dose of 2 × 10⁶ cells per kilogram, received an infusion of their genetically modified anti-CD19 CAR T cells. And some unique things about this is important to recognize that with a product that needs to be pheresed and then created and then shipped back to the patient, that there is a lag time between apheresis and reinfusion. And these are patients with refractory large cell lymphoma. And so we all know that these patients don't often have a very large window in order to get their treatment. This study reported a very quick turnaround time of 17 days of average time from pheresis and distribution back to the clinical site for reinfusion. And unlike some of the other studies, did not allow any bridging therapy between apheresis and reinfusion. Despite that, you can see that that the majority of these patients did ultimately undergo reinfusion, which is 91%. So there were a few drop-offs. 5 were due to SAEs, 1 due to product manufacturing failure. That was the only manufacturing failure in the study, and 2 due to non-measurable disease. But no patients did not receive their CAR T cells because they clinically decompensated. And that may also suggest a certain amount of patient selection. That said, they received their flu-cy. 2 patients did not ultimately get their cells back due to SAEs from the flu-cy. And so the analysis data set is going to be on these 101 patients who received their cells back. And this is shown in 2 different subsets. The primary analysis subset for approval is the diffuse large B-cell lymphoma subset, which here includes 73 subjects. They also allowed transformed follicular lymphoma and primary mediastinal lymphoma, which is a smaller group, only 20 patients there. If you look at how heavily pretreated these patients were, you can see they received a median of 3 or 4 prior treatments. The stage was advanced in nearly all patients, and 77% of these patients were refractory to second-line or later therapy, and 21% had relapsed post-auto stem cell transplant. If we look at their response, you can see among the 51 patients with diffuse large B-cell lymphoma, they reported an overall response rate of 76% with a complete remission rate of 47%. That's a really remarkable CR rate for a refractory population of patients. In the transformed follicular and primary mediastinal, the response and CR rate was also very good, potentially higher CR rate shown there, but again, the numbers in that analysis you can see are very small. So in the overall study, they found a 79% response rate, with half of those responses being complete remissions. Now, many of those were fleeting, and so if you look at the sustained CR rate at 3 months, that was 39%. So approximately 40% of patients remaining in a CR, granted still at limited follow-up of 3 months. Now, we can't talk about CAR T cells without thinking about the toxicity profile. And the dominant toxicities from this type of treatment come from the fact that we infuse these T cells meet their targeted antigen and suddenly get activated, and activated T cells release T cell active cytokines. And so the dominant toxicities are a cytokine release syndrome, which is primarily fever, can be hypotension and organ injury, and mental status changes. And true neurologic toxicities, probably from the cytokine storm that's in the central nervous system. We do find these cells and the cytokines surging within the CNS. And this can be everything from mild confusion to total obtundation or status epilepticus. And so what you can see in this study is that overall 92% of people did have a grade 3 or higher adverse event, so a high toxicity therapy, I would say. Now, 13% of patients did have grade 3 or higher cytokine release syndrome, and remarkable 29% had grade 3 or higher neurotoxicity, and that's very severe neurotoxicity. There were 3 fatal events in the study, 2 of which were attributed to the CAR T cells. Now, notably about the CRS and the neurologic toxicities, these were reversible in nearly all patients. There were only 3 neurologic events that were characterized as ongoing at the last data cutoff. They were all low grade, grade 1 memory impairment, grade 1 tremor, and a grade 2 tremor. And one patient died due to progressive disease with active neurologic toxicity, so could not be followed to resolution. The optimal management for cytokine release syndrome at least includes tocilizumab, which appears to reverse the cytokine storm fairly rapidly. Dexamethasone also appears effective. For the neurologic toxicity, it's not clear that toci is effective at treating the neurologic toxicity. It doesn't cross the blood-brain barrier, but steroids do appear to have some benefit in helping reverse the neurologic toxicity, and so you can see those were utilized in a number of patients on this study. An acute leukemia study had to be stopped because of grade 5 cerebral edema events. So I'll note that none of the neurologic toxicities in this study involved cerebral edema. The next study I'll highlight is data that we presented at this past ASH meeting. This is earlier data. This is from an ongoing phase 1 study. This is using a Juno compound, which is a CD19 41BB co-stimulatory molecule. It also has a truncated EGFR receptor, which allows tracking of the product in target tissues. And here you can see that in our study, patients are screened. Those patients who have PET-positive disease and meet eligibility criteria are collected. They are allowed in this study to get intervening chemotherapy, and a lot of patients did receive intervening chemotherapy, and the median turnaround on this product was about a month, so longer than I reported in the KITE study. Patients got flu-cy conditioning and then are assigned to different dose levels, dose level 1, 2, or 3, and also to either a 1 or 2 dose schedule to explore optimal dose and administration. The baseline characteristics are in small print, but I'll summarize for you. 28 total patients enrolled at the time of this analysis, but we are planning to update this data at the ASCO meeting. You can see 54% of patients had DLBCL NOS, 36% had transformed follicular lymphoma, a patient with grade 3B follicular, and a couple of patients with mantle cell lymphoma. 82% of patients on this study were chemorefractory based on the definition I highlighted earlier, and the median number of prior therapies was 4. So this is really a heavily beat up population of primarily large cell lymphoma. Just over half of patients had had prior transplantation. Most of those were autologous. If we look at how these patients were followed in this schematic, 4 mantle cell lymphoma patients were leukapheresed. 1 decompensated before JCAR therapy. 1 is awaiting the product at the time of this data cut, and so 2 patients are analyzable in the mantle cell cohort. Among the DLBCL cohort, 45 patients leukapheresed, and at the time of the data cut, 9 of those were still awaiting return of their product and so aren't included in the efficacy analysis. 5 had died or decompensated. Again, this is a longer turnaround time, potentially sicker patients being included in this study. This, I think, is the major risk of something that requires this much lead time to get the therapy to the patient. 31 patients ultimately treated with JCAR17, the CAR T-cell product, after their flu-cy conditioning. 2 of them are not yet evaluable at their 28-day response assessment, and 3 of them are not included in the primary analysis because they got what's called a non-conforming product, which means the CD4 and CD8 ratio weren't as protocol specified. Unlike other CAR T-cell products, CD4 and CD8 in this study are generated separately and infused in a 1-to-1 ratio. The majority of these patients, 20, were treated on the very first dose level with a single dose. And these are the initial response data. You can see among the 20 patients who were initially evaluable at that dose level, 16 responded for an 80% response rate, and the complete remission rate was 60%. So 12 of 20 patients achieving a complete remission on therapy. 4 PRs and 4 cases of progressive disease, and there was no difference in response rate whether they were in the majority of people who were chemorefractory or the small number who were not chemorefractory. If we look at those patients who were not on that first dose level, there were 3 patients on the 2-dose schedule at dose level 1, and that produced 2 PRs and 1 PD. Only 2 patients at the second dose level evaluable, and both of those patients achieved a CR. On the mantle cell cohort, 2 patients treated, as I mentioned, 1 PR of those 2 patients. And I'll also note, getting back to that unmet medical need, 2 double hits, 3 triple hits, and 4 double expressors were treated on this study, 7 CRs, 2 PRs. Every one of those 9 patients achieved a response. If we think about the neurologic toxicity and cytokine release syndrome, it may be a little bit less, although the numbers are small, and so it's too early to say. Overall, about a third of patients did have cytokine release syndrome, but at the time of this data cut, there were 0 cases of grade 3 or 4 cytokine release syndrome. There were 18% incidents of all neurotoxicity. 14% of those were grade 3 or 4. Only 1 patient at the time of this data cut required tocilizumab. 4 patients received dexamethasone. No patients required vasopressors. So in general, and as an investigator on this study, I can say it's been generally very manageable, and I think we're learning a lot on how to identify and treat these toxicities. In limited follow-up on this study, you can see here 10 of 14 patients who achieved a CR remain in CR at last follow-up, but as you can see, most of those patients are at or have not yet achieved the 6-month time point. So it's still too early to comment on durability. I will highlight our first patient treated on this study. Sometimes the very first patient you see either can be your most remarkable responder or your most remarkable non-responder. This is a 67-year-old patient of mine with chemo-refractory large cell lymphoma involving her soft tissues and her parenchymal brain lesion. I'll note that the parenchymal brain lesion appeared between her apheresis and registration and when she was rescanned immediately prior to CAR T-cell therapy. CNS disease involvement is actually an exclusion criteria, but given that her cells were already manufactured and she was so heavily pretreated, she was permitted to proceed with treatment on a protocol exception. This patient had 5 prior lines of therapy and an allogeneic stem cell transplant, and you can see at day 28, both the soft tissue periauricular disease and that temporal lobe brain lesion were in a complete remission by day 28. Unfortunately, the periauricular mass relapsed 3 months later, and it was biopsied and showed that that disease was CD19 positive still. The parenchymal brain disease remained in remission. While we were debating what to do and considering obtaining additional CAR T cells, the mass behind her ear spontaneously regressed and remains in remission with no further therapy 9 months later. And intriguingly, when we looked at her PKs, what you can see here is though she had an initial spike after her CAR T-cell infusion, the arrow at the time of her biopsy, shown there, led to an immediate spike in her CAR T-cell levels. So she spontaneously re-expanded, perhaps from exposure to tumor antigen at the time of the biopsy, and perhaps this is what led her to regain remission with no further therapy, and that has thus far been sustained. And I think, though this is an anecdote, it's perhaps a remarkable suggestion that this is a different type of therapy. It's a living drug that can potentially be manipulated to optimize outcomes. So in the near future, who's likely to receive CAR T cells? I think the chemo-refractory large cell lymphomas and those relapsing after auto transplant are the ones studied in the ZUMA-1 study with the most mature data and are an unmet medical need. And we would anticipate, at least the current prediction is that there may very well be an approval of that compound even before the end of 2017. In the more distant future, trials are being planned to look at chemosensitive relapse disease with a randomization of CAR T cells versus standard autologous stem cell transplant, chemorefractory or relapsing follicular lymphoma, mantle cell lymphoma, and CLL, those unmet medical needs I highlighted earlier, all have shown some benefit in the very limited numbers included in phase 1 studies, and further investigation is ongoing. I think there are significant challenges, but also opportunities with this treatment going forward. Obviously, we need to identify how to risk stratify patients for these severe toxicities and potentially institute prophylactic strategies, such as prophylaxis with tocilizumab in high-risk patients. The production time needs to be as short as possible, given the high-risk nature of these patients. Centers need to be trained and accredited to manage these patients, and of course, it's likely to be extraordinarily expensive when it's approved. Opportunities to make this treatment potentially even better, select the best potential targets, or even CARs that target multiple tumor antigens at the same time, optimize their persistence, combine them potentially with immune checkpoint inhibitors or immunomodulators to enhance their efficacy and prevent drug resistance, or even incorporate immune checkpoint domains into the CAR T-cell product itself, and potentially can we make these off the shelf. So I'll finally summarize by saying that anti-CD19 CAR T cells have potent, potentially durable clinical activity at least out to the 6-month mark in the phase 2 study in multiple refractory B-cell lymphoma subtypes that we would now consider unmet medical needs. There are on-target toxicities with cytokine release syndrome and neurotoxicity, which can certainly be severe, but are predictable in many cases based on the underlying disease burden and laboratory monitoring, and are usually reversible. Ongoing investigation is needed to define optimal application in different lymphoma subtypes, not just refractory large cell lymphoma, and to develop the optimal CARs and combinations to make these the most effective treatments possible. And ultimately, we expect that as early as fourth quarter this year, we may actually be thinking about commercial application in high-risk DLBCL. With that, I'll thank you very much for your attention.